Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes. Let's discuss a new topic, that's diabetic eye disease. So this is a second chronic complication of diabetes, type 2 diabetes mellitus as well as type 1 diabetes mellitus also. So let's begin with the name of Almighty then. First, coming to the concept and definition. So diabetic eye disease is a spectrum of progressive, visually devastating microvascular complications. It is a spectrum which is progressive, which causes damage to the vision by microvascular complication resulting from chronic, poorly controlled hyperglycemia. So primarily it is defined by two things. Mainly there are two types of diabetic eye disease. There is number one is diabetic retinopathy and number two is diabetic macular edema. Diabetic retinopathy is ischemic microvascular damage and abnormal new blood vessel growth, also known as neovascularization. So there is ischemic microvascular damage to the retina and there is abnormal new blood vessel growth in the retina, that is known as neovascularization. And diabetic macular edema is increased vascular permeability causing fluid buildup and swelling in the central retina, that is also known as macula. Increased vascular permeability causing fluid buildup and swelling in the central retina. Okay. So what is the epidemiology? Diabetic retinopathy is the most common microvascular complication in both type 1 and type 2 diabetes. Virtually all patients with type 1 diabetes and more than 60% of patients with type 2 diabetes will develop some degree of retinopathy after 20 years of disease duration. So all patients with type 1 and more than 60% of type 2 will develop some degree of diabetic retinopathy after 20 years of duration of diabetes. Despite advances in therapy, it remains the leading cause of new onset, irreversible blindness among working age adults 20 to 74 years in developed countries. Okay, it's the leading cause of new onset irreversible blindness, and that too in working group of adults. So that is the epidemiology. So why should we study this? Let's discuss. Number one reason is it is a silent threat. In its early non-proliferative stages, diabetic eye disease is entirely asymptomatic. Severe irreversible retinal damage can be occurring while the patient maintains a vision of 20 by 20. So no symptoms in the early stage. Damage can progress without warning. Second point, why should we study is the systemic sentinel. What is that? The retina is the only place in the human body where the microcirculation can be visualized directly and non-invasively. The presence and severity of diabetic retinopathy correlate tightly with diabetic nephropathy and diabetic peripheral sensorimotor neuropathy. So it is a marker of systemic microvascular damage and it is a marker of diabetic kidney disease and diabetic neuropathy. So that's why if diabetic retinopathy is there, then probably 90% of the times diabetic kidney disease is also there and diabetic neuropathy may have developed in the patient. And there is a macrovascular correlation also. The risk of catastrophic macrovascular events like myocardial infarction, stroke and cardiovascular death is independently elevated in patients with significant microvascular retinal damage. So cardiovascular death rates are nearly double in patients with diabetic microvascular complications. So you need to start preventive measures for this macrovascular disease also, like statins and aspirin. Third is quality of life and morbidity. Untreated advanced diabetic eye disease leads to profound visual impairment, loss of central vision seen in diabetic macular edema, or total vision loss from tractional retinal detachment or vitreous hemorrhage that destroys independence. It severely impairs ability to self-manage diabetes, example drawing, insulin checking feet, and it is associated with significant psychological morbidity also. So there is a blurred vision patient that leads to dependence of the patient. Patient will become dependent because eyes are very necessary to manage, no? So eyes are not there, eyes are not working properly, so patient will become dependent. So that's how we should study. So it has a relation with, so number one, so we'll finish this. Fourth thing is screening gaps. Despite clear guidelines, only approximately 50 to 60% of patients with diabetes undergo the recommended annual dilated eye examinations. This represents a massive failure in preventative care, necessitating aggressive primary care intervention. Only 50 to 60% of the patients get the recommended annual eye examination, so we should not neglect annual dilated eye examination in patients with diabetes mellitus. Very important, and in practical life we see these things very much. Seeing only the eyes can predict many things in patients with diabetes mellitus, as we have discussed. Like we will if eyes are not good, then kidneys are also not good, then the nerves are also not good, then the heart is also not good. Okay, these things we can predict by diabetic retinopathy, and we can prevent development of sudden onset of irreversible vision loss in the patient. So these are the reasons we should study. In the initial stages, it is what you call asymptomatic. So annual dilated eye examination is very important. Okay. So there are two things. That is, one thing is diabetic retinopathy and macular edema. Diabetic eye disease means two things: diabetic retinopathy and macular edema. So diabetic retinopathy and macular edema result from a stepwise sequence of events of metabolic toxicity, that is nothing but cascade of metabolic toxicity, microvascular damage, ischemia, and abnormal new vessel growth. The retina is highly vulnerable due to its high oxygen demand and strict dependence on an intact blood-retinal barrier. So what are the things which are happening? Chronic hyperglycemia leads to cellular toxicity first. So chronic hyperglycemia will lead to oxidative stress in the cells. High glucose will lead to oxidative stress, that is nothing but production of high amount of reactive oxygen species. Reactive oxygen species will cause damage to the cell. So this is the first trigger for all the subsequent damage. Why there is increased production of reactive oxygen species? Because increased amount of mitochondrial activity will take place. Mitochondria are the energy house of the cells. So more glucose enters in the electronic chain, and more ATP production leads to byproduction of this reactive oxygen species. The first trigger for the subsequent damage is oxidative stress. That means antioxidants are important to prescribe in patients with eye disease. Okay, then there will be activation of pathological metabolic shunts. These are also discussed. These are also play a role in diabetic kidney disease. We have discussed the polyol pathway, where the sorbitol accumulates, and the advanced glycation end products formation, and the protein kinase C activation. So polyol pathway, there is accumulation of sorbitol that will cause osmotic stress, and then there will be, we will discuss that, and AGS formation, they will cause thickening of the basement membrane, inflammation, and thrombosis of the microvasculature of the retina. Protein kinase C activation, that will cause increased permeability and altered blood flow, that is responsible for leakage of cholesterol and RBCs from the blood vessels in the retina. So these are the pathological pathways. These are activated. So what will be the pathological result of these insults in the retina then? So the microvascular structural collapse and barrier breakdown. So see, this is a normal vascular endothelial cell. So this has a blood retinal barrier in the form of pericytes. Okay, and there are tight junctions, and the basement membrane is also thick of this of the endothelial cells of this blood vessel. But because of these damages caused by this high glucose concentration, there will be first pericyte fallout. So these cells will fall off, and this pericyte there will be pericyte loss. When there is a loss of pericyte, the blood vessels become very fragile, and there will be next formation of microaneurysms, meaning there will be bulging of the blood vessels. So weak walls of the blood vessels will balloon out. That is known as microaneurysm, and that is the first sign of which we see in fundoscopy of diabetic retinopathy. So early loss, apoptosis of pericytes. Why? Because of this sorbitol pathway, advanced glycation end products, and PKC activation and oxidative stress. All these things will cause death of these pericytes, which support the capillaries, and because of that there will be microaneurysm formation. Weak capillary walls balloon out under pressure and will lead to microaneurysms. Next, there will be breakdown of blood-retinal barrier. So these AGEs and PKC damage the tight junctions between endothelial cells, loss of negative charge in the basement membrane that will lead to leakage of fluid, albumin, protein, lipids. So that will lead to diabetic macular edema, that is nothing but deposition of or accumulation of fluid beneath the macula and hard exudates deposition in the retina. You can see here there is a breakdown of barrier. So the tight junctions between the endothelial cells is broken down, and the basement membrane has lost its negative charge. That's why cholesterol and proteins will enter into the retina, and they will cause diabetic macular edema and this hard exudates and dot and blot hemorrhages when the RBCs leak out, and flame shaped hemorrhages, and all these things they will cause. Okay, then there will be capillary occlusion, progressive retinal ischemia. So diabetes causes a hypercoagulable state. There is increased platelet thickness, stickiness, and abnormal RBC deformability. Okay, because of diabetes, because there is hypercoagulable state. So that causes endothelial damage plus leukostasis that will cause microvascular thrombosis. So capillary closure expands, and that will lead to ischemia of the retina. Severe ischemia will cause nerve fiber layer infarction, and that will appear as cotton wool spots. See, normal capillary, there will be flow like this, and when there is thrombosis, there is blockage of the capillary. So blood flow to the retina will be halted, and there will be ischemia of the neurons, which will appear as cotton wool spots. Okay, so that is the thing. Okay, there will be leakage, there will be so this is the initial stages. Okay, so later what will happen, because the retina is suffering from hypoxia, so compensatory mechanisms will start acting on, and there will be development of new vessels. So hypoxia driven aberrant, meaning abnormal angiogenesis. So deepening hypoxia stimulates release of pro-angiogenic factors. Key mediators in this are two things: VEGF, nothing but vascular endothelial growth factor, and angiopoietin 2. VEGF strongly promotes new vessel growth and increases vascular permeability. See, when there is retinal hypoxia in the late stages of diabetic retinopathy, there will be increased VEGF, increased angiopoietin 2, and there will be endothelial cell activation, and there will be new vessel growth. But the problem with this new vessel growth is these new vessels are very fragile. They are leaky in nature. That's why these new vessels are harmful to the eye actually. Although it seems like, because the retina is not receiving oxygen properly, so these collaterals are developing to provide oxygen to the retina, but these new vessels are leaky, they are fragile. Instead, they will cause hemorrhages inside the retina, hemorrhages in the vitreous tumor. All these things, they will increase the damage in the eye. So that's why this neovascularization is not good for the eye. So proliferative complications will occur. Sorry. So proliferative complications will occur. So what will happen? VEGF drives growth of new fragile blood vessels, new vascularization on the retina, in the vitreous humor also, and over the iris also. So in the retina they will cause hemorrhages, in the vitreous again hemorrhages, and in the iris they can cause glaucoma, okay, rubeosis iridis, okay. These vessels lack support and tight junctions, that's why they are very fragile. They can rupture and cause vitreous hemorrhage, sudden loss of vision. Fibrovascular, this is also important, fibrovascular tissue grows with the new vessels, and this fibrovascular tissue, when it contracts, it will pull the retina and it can cause retinal detachment. Contraction of this tissue pulls on the retina and it can cause tractional retinal detachment. So that's why very bad thing is very bad thing it is. The growth of new vessel is very bad for the eye. So new vascularization, new fragile vessels grow on the retina, in the vitreous and over the iris. They will cause bleeding into the vitreous, and fibrovascular tissue which accompanies the new blood vessels, it will pull the retina and causes tractional retinal detachment. And one more thing is, because they grow on the iris also, they can cause angle closure glaucoma also in these patients. So this is step by step things which are happening. So just to summarize, first there will be chronic hyperglycemia will lead to oxidative stress, then there will be metabolic pathway activation, okay, microvascular damage initially in the form of microaneurysm, okay, hard exudates and hemorrhages, dot and blot hemorrhages, these things. Ischemia later the patient will have, that will so they will have cotton wool spots now, then there will be development of new vessels in the retina. So this is new vascularization. Then there will be proliferative complications. There are three main proliferative complications. Number one is vitreous hemorrhage, vitreous hemorrhage, massive vitreous hemorrhage. Number two is tractional retinal detachment. Number three is glaucoma, acute angular closure glaucoma. These three are vision threatening complications which occur in patient with diabetes. So that's about step by step pathological features of diabetic retinopathy as well as macular edema. One thing to remember is, because the leakage happens early only, that's why diabetic macular edema can occur at any stage of diabetic retinopathy. So this point is important to remember, that diabetic macular edema can occur, DME can occur at any stage of diabetic retinopathy, because leakage happens early. Here itself the leakage happens. Okay. Now coming to the classification and severity. So classification, one is diabetic retinopathy and another thing is diabetic macular edema. So first we will gauge the severity of diabetic retinopathy. So accurate clinical staging is the cornerstone of managing diabetic eye disease, dictating follow-up intervals, imaging requirements and thresholds for intervention. The globally accepted standard is the International Clinical Disease Severity Scale for Diabetic Retinopathy and Diabetic Macular Edema. So disease severity, so observable clinical findings and clinical rationale and prognostic implications. So in the first stage there will be no apparent diabetic retinopathy. So there will be completely normal retinal examination, no abnormalities visible. So this is the baseline risk state. The underlying metabolic environment is present, but macroscopic structural failure has not occurred still. So the underlying environment is present, but macroscopic structural damage has not occurred. Now comes the mild non-proliferative. So diabetic retinopathy, again it is classified into proliferative and non-proliferative. So proliferative is the last thing, PDR, so you can remember this, NPDR and PDR. So NPDR has three things: mild, moderate and severe. Then there will be PDR, next stage. Okay. So this is non-proliferative diabetic retinopathy and this is proliferative diabetic retinopathy, which is very much dangerous thing. Okay. So Coming to the mild type of NPDR, there you can see only microaneurysms in the form of red dots. You can see in this image here itself. This is a schematic representation. Okay, sorry, here itself you can see red dots. Okay, so represents early pericyte dropout and focal capillary weakness. Risk of imminent visual loss is low. Okay, then comes the moderate NPDR. In moderate NPDR, then the vessels will become leaky, and you will see hemorrhages, you will see exudates, okay, and you will see what do you call your cotton wool spots also. Cotton wool spots. Ischemia is started at this stage. Okay, leakage and ischemia is starting at this stage of moderate NPDR. More than just microaneurysm, but less than severe NPDR criteria. This may include dot and blot hemorrhages, hard exudates, cotton wool spots. Okay, you can see here in this image. So there are hemorrhages here, and there are exudates also here. This yellowish type and whitish type is nothing but, so this is ischemia, and yellowish type is nothing but hard exudate, and this reddish type is nothing but they are hemorrhages. Okay, this indicates progressive ischemia and capillary leakage nearing the critical threshold for hypoxic drive. Then comes the severe NPDR. So to diagnose severe NPDR, we follow a rule known as 4-2-1 rule. So to say the patient is in severe NPDR, patient must need any one of the following with no signs of proliferation. So what are the 3 points of which one the patient should meet? Number 1 is more than 220 intraretinal hemorrhages in all 4 quadrants. To divide the eye in this format. So count the number of hemorrhages. If they are more than 20, then that is severe NPDR. And venous bleeding in at least 2 quadrants. Venous bleeding is nothing but, normally the veins are thick and the arteries are thin. Remember this point. Veins are thick, arteries are thin in retina when you see through fundus examination. But these veins are not tortuous. They are not tortuous and they are not engorged. So venous bleeding is nothing but the veins become tortuous and saccular in shape like this. This type the veins will become. So this is known as venous bleeding. So this venous bleeding should be present in at least 2 quadrants. 2 quadrants, at least 2 quadrants. Then prominent intraretinal microvascular abnormalities. So tree-like proliferation of blood vessels, but they are micro. Okay, that is known as IRMA, intraretinal microvascular abnormality in the retina. That should be present in at least 1 quadrant. So normally you will see, so like this, if this is the fundus, like this vessels you will see arteries. Okay, so in the severe NPDR, what you will see, you will have some micro like this collateral vessels, micro very thin collateral vessels like this, leaf tree like it is shown here like this. So this type of collateral vessels you will see in the retina. So they are known as intraretinal microvascular abnormalities. IRMS. At least 1 IRMS should be present. At least in 1 quadrant IRMA should be present. Okay, so 4-2-1 rule. So either hemorrhages more than 20 in all the 4 quadrants, and venous bleeding in at least 2 quadrants, and IRMA in at least 1 quadrant. So this represents profound widespread retinal ischemia, and eyes at this stage have a more than 50%, more than half chance of progressing to high risk proliferative diabetic retinopathy within 1 year if untreated. So these type of patients who are having severe NPDR, they are prone to develop proliferative PDR in more than 50% of patients in 1 year if they are not treated. This point should be remembered. So next thing is the last and the baddest, the worst thing, which is the thing is PDR, proliferative diabetic retinopathy. So you will call it as proliferative if one among the 3 is present. There should be neovascularization at the disc, formation of new blood vessels at the disc, or formation of new blood vessels anywhere except the disc, or there should be pre-retinal or vitreous hemorrhage. So neovascularization at the disc, okay, and neovascular elsewhere, okay, except the disc, and pre-retinal or vitreous hemorrhage. So if these one among these three is present, then the patient is said to have proliferative diabetic retinopathy. So this represents end-stage hypoxic response, extremely high risk for sudden, severe and permanent visual loss via hemorrhage or retinal detachment. Key takeaway is the progression of diabetic retinopathy reflects increasing retinal ischemia. Early detection and timely management can prevent vision-threatening complications. Regular screening is essential. Type 1 diabetes should have screening from 5 years after diagnosis, and type 2 should at the time of diagnosis. Follow-up frequency based on diabetic retinopathy severity. So usually it is every yearly. That's about diabetic retinopathy severity scale. Now coming to same thing we will see here, fundus images. See, this is a normal fundus. So this is the optic disc, and this is the macula, and these are the arteries. The thin ones are the arteries, and these are the veins. These are two veins. Okay, this is the normal fundus. Now this is mild proliferative diabetic, mild NPDR. So you can see red dots here. So these red dots represent microaneurysms, but you are not able to see any hard exudate or any hemorrhages or cotton wool spots. Just you are able to make out red dots. So that is mild NPDR. Then you can see here red dots are present, and here you can see this is the cotton wool spot, whitish, and this yellowish type of which you are seeing now. So these are hard exudates. Okay, but they are not so much that you can say it is severe NPDR, more than 20 in 4 quadrants, or more than 2, at least venous bleeding in at least 2 quadrants, or IRMA formation in at least 1 quadrant. This criteria is not met here. Here in severe you can see the hemorrhages. These are all hemorrhages. So number of hemorrhages, yes, obviously it is more than 20. And if you see in this image, because it is an image, so there are microvascular IRMA also, anastomosis type things, they are nothing but, okay, IRMS also. There is venous bleeding also. So you can see these thick ones are veins, and they have become tortuous now and become saccular. You can see here, they are tortuous and saccular. So this is a case, by seeing hemorrhages only you can say this is a case of severe NPDR. Now you see a case of PDR. You can see the network of capillaries here, the network of arteries. So this is neovascularization at the disc. The disc is very much covered with new blood vessels, and also you can see a vitreous hemorrhage here in the lower 2 quadrants, if you divide like this. So this says that there is proliferative diabetic retinopathy. So this is about the real fundus images of diabetic retinopathy. Now coming to the diabetic macular edema. You should always grade diabetic macular edema separately. So diabetic macular edema must be graded independently of diabetic retinopathy severity. Center involved diabetic macular edema is the leading cause of vision loss in central vision loss in diabetic patients. Now, so we should remember always these things. Fundoscopy. Second thing is for knowing diabetic macular edema. This is optical coherence tomography, OCT, or also known as macular B scan. So these two things we use for knowing macular edema, diabetic macular edema. So when there is no diabetic macular edema, so this is the macula. You will see no exudates here, and this is the thinnest point of the retina. So this is the thinnest point of the retina, and you can see the concave shape of retina. This is known as fovea. Okay, fovea. This is thinnest point of retina, but there is no deposition of fluid beneath this. No deposition of fluid beneath this here. So this is normal thing. Now when you go to, so this edema can be graded into mild, moderate, and severe. So when it is mild, retinal thickening or hard exudates present in the posterior pole but situated distant from the center of the macula. You can see there are hard exudates, but they are away from the center of macula. Here also you can see this is the center, this is the fovea, and these blackish things which you are seeing, these are nothing but exudates, and these whitish things are nothing but exudates, and this is fluid actually. So they are present away from the fovea, they are present away from the macula. So that is mild DME. So this is OCT. Now moderate DME, retinal thickening or hard exudates approaching the center of the macula but not directly involving the foveal center. So the fovea is spared, but they are approaching the fovea now. See, they are now, see this convexity around the fovea is increased. Here see the convexity is not that much, this is more horizontal, but here you see the convexity, it is very much increased, and you are able to see here the fluid, but it is not involving the fovea. So that is moderate diabetic macular edema. And in fundus you will see approaching of these exudates towards the fovea. Now severe DME, nothing but center involved DME, CIDME, retinal thickening or hard exudate directly involving the center of the macula, loss of foveal depression on OCT, large cystoid spaces, directly correlates with marked visual acuity reduction. So you can see, so now the macula is covered, it is encircled by exudates, and in OCT you can see that the concavity is lost, and concavity, this is the fovea actually, and this concavity is lost, and because of this deposition of fluid, so this is raised now. So this is CIDME. So this is the severe form of DME, CIDME. Okay. So what is the importance of this then? What is the importance of this? So in mild DME, vision is usually good, risk of progression is present. In moderate DME, vision may be affected, high risk of progression to CIDME. Okay, vision may be but the high progression to CIDME. But in severe, it directly correlates with the marked visual, there will be marked visual acuity reduction in severe, that is nothing but CIDME. So that's about the severity of diabetic macular edema. So every time the severity of diabetic retinopathy DR and DME should be assessed differently. Okay, differently they should be assessed. Okay. Okay, I think this is enough for now, and we will discuss in the next class. Thank you.